So we all have a sense of right or wrong. It's almost innate. Scriptures talk about it. It already lies in our hearts, that determining that. That's what we call conscience, that value system. So I often relate all of this to what I call the three-legged stool, that you got to have all three. I remember milking on the farm. We had a three-legged stool. One of them broke. What'd happen? Yeah, fell over, spilled the milk. And Mom and Dad didn't really care if you hurt yourself falling over, but they really cared about whether you spilled the milk or not, teasing a little bit. So with regard to that three-legged stool, that we have a sense of moral character within us. And we know when we do wrong, we're immoral. When we don't have a sense of right or wrong, that's where you really get to the dangerous person. That's the amoral person. I think you know in your trial experience, those were the most dangerous criminals around, who simply didn't have that sense. It's almost hard to imagine. We have the formation of our moral sense of values. The family we're raised in is very important. We also have the group around us, the community. We have a lot of peer group pressure. A lot of the things we do as teenagers, or a lot of it depending on what did the rest of them do. We got to, excuse me, keep up with the kids, that kind of thing. I find it amazing, well, really not amazing, when did most people start smoking, when they were smokers as adults? As teenagers, they had to keep up with the kids. I broke the habit when I was 6 because I got into my brother's tobacco, his pipe, and got sicker than a dog and threw up, and he says, this is not fun. So I never did get into smoking, but I think we overcome it and get addicted because of that group pressure. The word moral comes from mores, the customs, the practices of the people. So as important as conscience is, it's not absolute. So we need something else, another part of the stool. And when you now equate this with medical ethics in every professional group has a code, we call a code of ethics, determining as a professional what's the right thing to do. So what's the right thing to do as a doctor in terms of staying in line with what the profession says a good doctor should do? So that's the ethics part of it, but we know too, that's not absolute. We've got a lot of unethical practitioners out there with regard to even the question of life at its vulnerability at the front edges and life being vulnerable at the back edges. We're getting into a lot of unethical practices. So we need another leg in terms of what I call the legal. That's not absolute either. So when I'm driving down the highway, I want to go 100 miles an hour to get to the next workshop you planned for me. The law says that may not be the right thing to do. Even when you're looking at just and unjust laws, if your skin was too dark and you lived in Alabama in 1950, could you eat in any restaurant you wanted, go to any restroom you wanted, or sit on any part of the bus you wanted? Why not? Because the Jim Crow law says it was illegal for you to do that. You had too much melanin. Your skin was too dark to do that. So again, the law keeps me from misbehaving because my conscience says I can drive 100 miles an hour. No. Or my profession says I can do it. No. And the law says, no, you can't. So you've got those kind of things always going back and forth. I call it a checks and balances. So with regard to bringing this all to bear to medicine, we've got a lot of movements out there that may be legal. It may be the profession says it's okay, but we still got to bring in the other element, the moral, and flipping it back and forth that way. That's what I have in terms of mind when I talk about determining the right thing to do, using these checks and balances, the three-legged stool. None of them absolutely control. They all have to depend on each other back and forth. That's what I would say. And even when laws are passed, say, to hasten death, I think we're going to talk about that a little later also, there still needs to be, in most of those laws, that legislation has a provision about maintaining the right to that person's conscience. The individual is not forced to violate their own value system, their own conscience, by now going along with the dictates of the law. With regard to that, going now even to the point of the ethical principles, the question of autonomy and advanced directives, where this individual had renal failure, kidneys were not functioning anymore, was on dialysis, and he decided enough was enough, that he was too compromised. And he told the doctors to stop the dialysis, the hemodialysis. His daughter, only child, was totally opposed to that and says, Dad, you can't let that go because his kidneys were absolutely in failure. So once the dialysis was stopped, no longer removing the toxins, the poisons from his body, he would gradually lose awareness, go into a coma, and eventually die from the kidney failure. So he had also named his daughter to be a power of attorney. And power of attorney is triggered when the individual loses decisional capacity. Remember, she was opposed to him going that route, but he was still in charge, in control. So the doctors decided he's right, he's not getting benefit from this intervention, and stopped the dialysis. He went into a coma, he lost decisional capacity, and guess what? The daughter now legally was in charge. He had decided in moral, his conscience, this was right. The ethical dimension was, this is the right thing to do. He's not getting benefit from it. But now you've got the law coming in, and the law says she's in charge. So she immediately said to the doctors, the medical community, hook him back up to dialysis. And they said, well, he doesn't want it. He's not in charge anymore. And then she says, if you don't hook him up to dialysis and he dies, I'm going to sue you for wrongful death. Well, that got the attention of the medical professionals. So they hooked him back up, cleaned out his blood, he regained awareness, and he woke up. He was really angry. He was very, very angry about it all. And he said, what are you doing? I told you I didn't want this. Well, your daughter said. Well, I don't care what my daughter says. Well, you named her legally to be power of attorney. So they were in a dilemma. They don't know where to go. So I serve on the ethics committee for this particular hospital, and they called me. I said, what do we do here? So I says, clinically, is he benefiting from this? No, his body's too compromised. It's really, we've answered the question pretty easily. Enough is enough here. And so they explained with regard to the legal aspect of it and her threat to sue. So I asked him really point blank, so ethically, as a professional, medical professional, what do you think is the right thing to do? And he said, well, not to do dialysis. But again, they go back to the law very quickly. And I said, as far as I know, there has never been a lawsuit in Kansas where a medical professional has been found guilty for practicing good medicine. What are you going to be found guilty of if it gets into the court of law in terms of medical practice here? Practicing, you know the answer there, bad medicine. So is it good medicine or bad medicine here? Well, good medicine is to stop the intervention. That would be the ethical thing to do. So it says, really what you're asking me, and I might use the bad language here, you're really asking a CYA question, and you can fill in that blank later on. So they decided not to go with the daughter's directive. They didn't hook him back up. He died, and she never did sue. But you see what I'm getting at in terms of that three-legged stool? I think a perfect illustration of that, how those three need to be brought into a checks and balances kind of system. Determining the bottom line, the right thing to do. Physical existence doesn't have absolute value. Therefore, we don't have to do absolutely everything in terms of medical intervention simply to hold death at bay. That's both moral, legal, and ethical in situations where you've done. And by the way, I never give advice until I know the clinical background. So I explored with the medical professionals on that call. Give me the clinical facts here so I get an idea whether or not this individual is going to find dialysis beneficial in terms of the deeper question of what life is about, which I said earlier was being able to continue having a body that serves us so that we can now know, love, and serve. In secular language, engage in good cognitive affective functioning. That's where we have to start making those determinations. My point earlier is you got to be able to engage in some good analytical, critical thinking to sort out these difficult, complex questions that modern medicine poses for us. Absolutely. I have encountered so many medical professionals who on that first leg of the stool, the moral, have felt themselves having, if they can do it, they must do it. The moral obligation, if I can, I must have an obligation. No, that does not hold whatsoever. Simply because you can, you do not have a moral obligation to absolutely do it. In terms of even the bishop's teaching on that, I put that away here, got it somewhere, but they make it very clear in terms of those obligations we have to do or not to do. Let me just go ahead and quote those directly. This is 56 and 57 on that same chapter. And it couches it in moral obligation. An individual has a moral obligation to use ordinary or proportionate means of preserving his or her life. That's sanctity of life, again. Proportionate means are those that, in the judgment of the patient, offer a reasonable hope of benefit. So again, why? The benefit is no love is served, being able to do the cognitive affective functioning. And the reasonable hope of benefit also then says it does not entail an excessive burden or impose excessive expense on the family or the community. And then they're simply stating that point again in 57 in a negative way. An individual, a person may forego extraordinary or disproportionate means of preserving life. Again, physical existence. Disproportionate means are those that in the patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. So the benefit burden even goes into the justice question of expense or lack of expense. I want to make it very, very clear that the Catholic Church has never categorically taught this philosophical position of vitalism. That the goal of medical intervention is simply preserving a warm body, keeping a vital body around, keeping vital signs going. That has never been Catholic Church teaching. That, as we said earlier, physical existence doesn't have absolute value. As important as our bodies are, they're not absolute. Sooner or later, whether we like it or not, our bodies get so compromised that the healing we need to go through, as I said earlier, is letting the body go and being freed from a body that doesn't serve us anymore. So this question of integration is so very, very important. Integration of all the functions of our body, serving as one. And when you've got one party that's no longer working anymore, the body, then the right thing to do is to let it go. Not to hasten death. Now, don't misunderstand that. We'll reference that later on too. You've got to look at it from the ethical and the clinical both, because there's going to be a difference there. If you're looking at it from the clinical, what would be considered ordinary is easily done, doesn't cost a whole lot, all of those kind of factors. If readily available, that would be ordinary. And so if you're looking at it from the ethical and moral, then you would be obligated to do that. Versus in the church teaching, in the ethical perspective, you're looking at it now from, will it enhance that ability to cognitive affective functioning? Will it enhance our ability to know, love, and serve? Or will it get in the way? If it's going to get in the way, the ethical, the right thing, then it would be disproportionate, it would be extraordinary, no matter how simple the procedure would be and how readily available the commodity you're going to give, from air to water to food. If it's not going to enhance the knowing, loving, serving, then it's extraordinary. Versus the clinician would say, well, that's easily done. That's not extraordinary, that's ordinary. That's why I say there's going to be a little bit of disagreement between the clinician and the church teaching, the ethical teaching. So that's what we really need to be very, very clear about in terms of what the church talks about in terms of this benefit burden, ordinary, extraordinary. Now, it sounds bad to say that it's a bit on the relative side or the proportional side, but even the church, the Vatican document on euthanasia issued, I believe, in 1980, off the top of my head, don't take that as absolute, but they made it very, very clear that the circumstances of that person's life will make a difference in terms of determining whether it's ordinary, extraordinary, beneficial, or burdensome. So the 35-year-old mother of 3 young children with breast cancer might say, I want to go full bore. I want to, no matter what the side effects are for the cancer treatment, I want to get extra time to take care of my children. Versus the 94-year-old great-great-grandmother with the same situation says, I've lived a good life. I've fulfilled my mission, my purpose, my why for being here. So the 34-year-old might say, I want to go full bore. The 94-year-old says, no, just let it be.